So dentistry, obviously, but a big aspect of that, big concern that we have certainly is with pain and inflammation. And we're not just going to talk about pain. I'm going to talk about some inflammation too, because as I've started getting more resources, talking more about senior care, in fact, chronic inflammation impacts everything. It's probably that more than even the bacteremia from dentistry. That inflammation can impact everything systemically, including aging. And when we talk about oral and dental pain, we certainly know there's a lot of reasons that we can get some discomfort. Periodontal disease typically is a slower acting disease, so we don't get as much acute pain, but it certainly can cause issues. And remember that inflammation. Acutely fractured teeth while the nerve is still alive is an issue. Tooth resorption, both dogs and cats. Trauma, but also with chronic pain. And then we'll look at what we do for both operative pain and then extraoperative when we're talking about some of those chronic pains. One of the interesting thing about teeth is as we look at the afferent fibers, many different things can be sensed by these nerves. Heat, cold, pressure, pain. What the brain perceives as it makes it up that chain is pain. It can't distinguish between hot and cold. Certainly your gum tissue and everything else can do that, but it's a very self-preservation mode. If any of these sensations are transmitted, that means a tooth is having some kind of issue. The brain feels pain, and we all know what a toothache can feel like. So as we look at our oral and dental pain, it's really important. It's even more so important with our pets because their mouth is even more than just apprehending food. It's what carries things. It's what grooms them, everything along those lines. So periodontal disease. In people and somewhat in dogs and cats, we call this a silent disease because you can have a slow, gradual, but pretty extensive progression, but with minimal overt pain or discomfort. And especially with dogs, they're still eating. A lot of times because they're not using their teeth to eat. They're just swallowing teeth whole. As I said, we always talk about the infection, the bacteria that gets in the bloodstream. That happens every day, every time you eat. It's really on the human side, in fact, looking very closely at the chronic inflammation and not dealing with that chronic inflammation and where those systemic issues can make a big difference. There can be acute pain with periodontal disease if there's mobile teeth, if there's ulceration, and even when we treat. So we're going to definitely talk about using pain medication for periodontal treatment, even without extractions. Excuse me. With broken teeth, when the pulp is initially exposed, such as in this lower canine tooth, the nerve is exposed and it does hurt, but the nerve dies within a few days. And there may still be a little bit of bleeding due to granulation tissue and whatnot. We might not see any kind of infection or abscess until much later. But again, that chronic inflammation. Now in people, it has been described when they have an apical abscess that it can have a flare-up that's called a phoenix abscess. And with this exacerbation of the inflammation, because especially if there's no drainage, can cause extreme pain. But what about those other compromised teeth? What about a tooth that has blunt trauma, that purple or gray tooth? That also has chronic inflammation. Eventually, it may abscess, and so we have to watch out for those as well. So if you see those the blunt trauma teeth or the chronic pulpitis, they still need to be treated. And certainly if there's rough edges to that broken tooth, or if we have the slab still there and it's causing some irritation, then we might have some discomfort as well. Tooth resorption, and our most typical type is our odontoclastic tooth resorption or replacement resorption. This is where on radiographs, the tooth is completely being turned into bone. While it's still just in the root, there's likely not a lot of discomfort. But once it goes into the crown, then it is uncomfortable. I've heard some lecturers talk about touching these lesions with a cotton tip swab to exhibit the pain to the client. I hope you could, in preference, talk about the pain, not have to demonstrate that pain to them. So real quick, total teeth ablation, 3 remaining root parts with no reactive bone. It depends on what your extractions are for. If it's this tooth resorption, you can usually get by with some crown removal, what I call modified extraction. But if it has the inflammatory type, where we still have some roots down in there, we need to get all the root out. Or if it's a stomatitis cat, we need to get all the roots out. Certainly, if we have traumatic injuries, there's going to be pain. And at the same time, I'll see dogs walking in with these still wagging their tails and trying to eat and everything else. We have to assess the jaw injury. We have to assess the tooth injury within that area, any soft tissue damage, and even TMJ injuries, which can end up causing some chronic issues as well. Now, outside of acute pain, we can have some chronic disease. We certainly see that with our chronic stomatitis in cats, but we can also see an ulcerative stomatitis in dogs. Both of these conditions deal more with the dysregulated immune system than any level of bacterial infection, although viruses are a component likely of feline stomatitis. When we see this kind of ulceration, a lot of times extractions are needed. Certainly in cats, we know we need to go with pretty extensive extractions. In these ulcerative dogs, cleaning the teeth may help, but there's plaque there right away within a very short period of time. So again, usually extractions can make them much more comfortable. These ulcerations are typically on these dogs on the buccal surfaces that contact the tooth surface. That's why we call them kissing lesions. Oral tumors can also cause pain and discomfort. Number one, we usually don't get to see an oral tumor until it's so large that the patient is chewing on it. And then we've got bleeding and discomfort that way. If there's any tumor that has some osteolytic or osteoprolific changes, that tends to be painful as well. So whether or not we can treat definitively with a surgical cure or other methods, we definitely need to manage their pain because of the tumor effect of what's going on here. And we'll talk in a little bit about how I prefer using something like piroxicam on these cases. Another unique chronic pain that cats have, of course, cats have unique syndromes, is FOPS, F-O-P-S, feline oral pain syndrome. Now, about 80 to 85% of these cats are Burmese cats. So yeah, there's probably a genetic component. And with any trigger, any kind of inflammation, so teething kittens can go through this. And then later when they're older, if they have dental disease, periodontal disease, even stress triggers can cause this pain syndrome. It's been identified as a neuropathic pain disorder, in fact, specific sensitization of the trigeminal nerve. And it's kind of interesting how we approach the treatment of that we'll chat about in just a bit. Sometimes our chronic pain will be more indistinct. That older dog that's pawing at its face, rubbing its head against the floor, that kind of thing. So do we see possible neuropathies, either due to disease or possibly irregular extractions? Could we have temporomandibular joint dysplasia with osteoarthritis? Don't forget to also check the neck for any pain, the ears for any issues, even hair getting to the mouth, or even some cognitive issues with some almost like OCD type problems. So we'll look at how we manage those as well. Back to surgical. As we look at surgical pain management, I'm sure everybody's been through a lot of different seminars. We talk about multimodal. I like using the cocktail effect. We try to use whatever we can safely use on that individual to help stop the pain and inflammation early on. And that may be a combination of opioid that I really like for sedative effect, but I prefer the opioids that have a little bit more pain effect with my dentistry. So something like butorphanol will sedate them, but the pain won't last very long. So I'm going to reach for Hydromorph or Buprenex or something along those lines. I also like using some sedation with the benzos. So I like using midazolam either preoperatively or sandwiched in with my propofol or alfaxolone. If it's appropriate for the patient and renal health and even liver health is good, NSAIDs help with inflammation and pain using a small amount of an alpha-2, and then we also use meropitant on a regular basis. So preoperative, we want something typically with dentistry that's going to do a little sedation is important, but pain is very important. So looking at the morph type drugs, I know we tend to use the hydromorph. Sometimes that was tough to get. Sometimes we had to use morphine. Fentanyl type drugs are very potent, but have a short duration. And we do have some considerations now in watching about keeping them nice and safe and fully recorded. As we look at buprenorphine, we're looking at that partial mu antagonist, and I'm really fond of it in a number of different areas, and we'll talk about that soon too. Butorphanol for sedation, for short analgesia is good, but again, with most of my dental procedures, I'm going to look for something with a little longer acting. And then certainly your opioids can be used in many continuous rate infusion for combinations for extensive pain. So if we do have good renal function, I can use it preoperatively to help bring down that level of inflammation. And sometimes that even helps me with the tissues I need to work with. If I do have renal concerns, then I'm going to consider about using for recovery, or if they've had any issues, I might avoid. And certainly we have many different opioids, NSAIDs that we can use. If I do have my tumor patients, whether or not it's a surgical case or palliative at times, I tend to reach for piroxicam, and I'll go with 0.3 mg per kg for those tumor cases. If you have a patient around 70 pounds or so, the human form that's 10 milligrams is usually pretty good size. But if they're smaller, then you're going to have to get that compounded. But I do like going with piroxicam when I'm looking at pain management for either cases we're treating for tumors or even for palliative care. Now, our alpha-2s, I'm quite fond of because it gives me that sedation, but it also helps potentiate the analgesia, and usually in combination. In fact, we use a fairly low dose when doing combinations, and we are more careful with patients that have any cardiac issues. If you have any concerns about blood pressure, you monitor that well. Heart rate, you monitor that well. In fact, there's a pretty interesting, it's called the Dexdomitor Remix on YouTube. That's pretty fun. You'll have to watch that sometime. The one thing I like about it, and in fact, with most of the drugs we use, it's reversible. My midazolam, I reverse with flumazenil if I need to. But when you can use it preoperatively at low doses, it really helps that roller coaster ride. And if you do have any post-op dysphoria, a tiny, tiny dose is usually helpful with that as well. So at this point in time, most of my patients, we give the injectable meropitant or Cerenia because I haven't seen a lot of them previously. But if we get patients in for a consult, or if you're certainly seeing your patients, you can dispense an oral medication that they can use the night before or even the morning of your surgery. We allow water until they leave the house, and we don't mind a small meal up to about 4 hours before surgery. But when we're looking at this Cerenia, it does help with nausea. But we've also found out that there, with that substance P inhibition, some help possibly with some of the discomfort. We have lower inhalant. We have smoother recoveries. So we're using it on our patients pretty much across the board. When we've identified those areas we need to work on, and I'm talking any procedure, extraction, certainly trauma, repair, doing maxillectomies, but even if I'm doing periodontal treatment with root planing, things like that, I'm going to block the area. I'm going to numb it. Because once they're not feeling any pain in that area, even though anesthetized, we can keep their anesthesia lower. I do watch the total dose in small dogs and cats, for sure. So let's just skip which, it binds transmission and transduction, ion selective sodium channels, good. So my agents for my local blocks. I know lidocaine works quicker, but it doesn't last as long. So I tend to use bupivacaine. Place it early. As my technician is getting the radiographs done early on, if I know I'm going to be extracting something, I'm not going to be cleaning that tooth, at least not much, maybe popping off some of the calculus to be able to section the tooth. But I get my blocks in early as well. So we try to identify the places we're going to be working. I prefer the marking with epinephrine that's a premix if I can find it. It's tough to find. I won't use it certainly if I have any cardiac or arrhythmic type issues. And with our dosages, I'll go up to 2 mg per kg for dogs, but I'll limit 1 mg per kg for cat. And an 11-pound, 5-kilogram cat, that's 1 cc. So it's a cc or less, I drop it the entire dose at the beginning, so I don't have to remember how much I drew up in my syringe. And I make sure that I distribute it according to the sites I need. Now, I really like the bupivacaine with the epi because that 3 to 4 hour of bupivacaine goes out to about 6 to 8 hours because there's vasoconstriction, and it also helps with bleeding a little bit if you use it a little bit more locally. You can also extend the effectiveness of buprenorphine by adding 1 part of buprenorphine to 9 parts bupivacaine. Actually, I end up adding the 910 cc to 110 cc buprenorphine in the syringe, my larger dose of bupivacaine into the buprenorphine to mix it up well. And this can extend analgesia. But when I can, if I know I can get the 10 mil vials now of Nocita, I'll reach for Nocita and I'll use the same volume dose that I use my bupivacaine. And here I can get up to 72 hours. We've got that gradual release of liposomes. If I've got enough procedures that I can extend this out, I'm comfortable using it over a 4-day period. There's some white papers that tell us it's still stable at that point. These days in my semi-retirement, I'm only working on Tuesdays and Thursdays, so I can't always use it all up. But if I was 5 days a week and using it for other surgeries, this would be my go-to for sure. I'm going to chat just a little bit about some intraoperative blocks, and particularly with a caudal maxillary block. Certainly, as you start going into tissues and not just doing local blocks that are into the loose alveolar mucosa, you do need some training. Skulls Unlimited International is a great resource for getting skulls. I recommend getting a dog skull, a cat skull, and a brachycephalic dog skull, which are the 3 main species we deal with. Yes, the brachycephalics are different. Many people have heard about doing the infraorbital block, going with your needle no further than the medial canthus, doing a slow infiltration, and basically, if you can get it all the way back to that medial canthus, you're depositing material of the distal aspect at the pterygopalatine fossa. And this will desensitize the teeth, most likely the upper 4th premolar on forward. Some people also talk about using a catheter. The thing of it is, when you look at cats or brachycephalic dogs, that infraorbital canal is not very long, and you have got the orbit right there. Some quick question about Nocita being mixed with buprenorphine. I would not recommend doing that because of the stability of the lysosomes. There's no data about that. So if you put it just in front of this canal, you'll desensitize soft tissue forward. Unknown how much will actually infiltrate into the nerves that get to the teeth. So we talk about caudal maxillary blocks, trying to block this maxillary nerve before it goes into the infraorbital canal, becomes an infraorbital nerve, because there are branches that innervate these molars back here before it goes into the infraorbital canal. Now, you can go straight up behind that molar, the eyeball's right there. I've seen demonstrations of going in perpendicular to the cheek, which you'd probably miss the eye there, but it's not as directed. So how I approach this maxillary block is I come from behind the dog. I palpate the zygoma, and I keep my needle and syringe parallel to the palatal bone, just dorsal to it, distal to the zygoma. It's called subzygomatic approach. And as you're following that inside ridge of bone, you're basically aiming towards the opposite nostril. I'll then inject, certainly pull back, then inject at the caudal aspect of the pterygopalatine fossa, but I'll also slowly inject as I withdraw the needle and syringe so I can get that distal upper fourth and my molars. All right, so that's that's my caudal approach to the maxillary block. Mental blocks, I kind of like the name of it. Studies have shown that it's somewhat variable as to how much it can actually block. Certainly with a larger dog, if I can get a small needle and infiltrate it gently into that canal, I believe I can get the 2 premolars, maybe up to the 3rd premolar there, and the apex of the canine on forward. So I do like doing this one. The caudal mandibular approach, when you're trying to get the caudal aspect of the mandibular canal for your inferior alveolar block, part of it is trying to determine where that opening is and keeping the material close to the bone itself. If you get too large of a volume or you go too far medially, that's when we could have impact on the lingual nerve. So here we are, halfway between that last molar and your angular process is the caudal opening to the mandibular canal. You can either come through the skin as you're palpating it, walking just inside that bone, or you can come from an intraoral approach too. What if you're not comfortable with regional blocks or there's a lot of infection, inflammation where you're trying to place your block? At least do a line block in the buccal mucosa above the attached gingiva. That way you'll be getting some soft tissue, probably in the maxilla, a little bit of the maxilla because it's a bit more porous than the mandibular bone. But then even once you raise the flap or you start sectioning the tooth or cutting into bone, you can drip a few drips of your block in that area specifically. So perineural around the nerve. All right, beyond the blocks, looking at providing additional pain management for our patients, CRIs can be a very helpful to our pain management. And there are many protocols out there. Talking about the ketamine with your NDMA receptors can be an absolute help with this type of pain management. Talking about 60 milligrams, added 500 mils of fluid with a loading dose and then a slow rate, with or without lidocaine, with or without morphine. As you look at your opioids, you can use everything from morphine to hydromorph, fentanyl, oxymorph, and I will direct you to this VASG, Veterinary Anesthesia Support Group, VASG.org. Although it looks a little bit old-fashioned on the cover, it really has some good CRI calculators in there. It's got information for specific drugs and information about specific diseases. It's not done by an anesthesiologist, boarded anesthesiologist, but it has some good practical information. So we've got them through the operative phase. Now we're definitely going to think about doing something post-operatively. Whenever possible, we're going to use our NSAIDs because not only is it pain, but it's for inflammation. Okay. Cats, buprenorphine, certainly good mucosal absorption. We do have the longer injections that we can use with the Symbidol. And now I didn't put it in the bullet points, but Zorbium is available for cats. And that is our go-to with everything but the simplest procedures, because it's easy for us to administer to the cat before it goes home. They don't have to worry about getting that mucosal buprenorphine in for the cats. And so far, we've had some very, very good results with it. We'll talk about gabapentin as either an add-in if we're worried about chronic pain or additional pain, but not as a standalone, but we are definitely going to be using it the night before and the morning of, when at all possible. So whenever you have your own patients, think about prepping them for that procedure. Can you send home gabapentin for cats or trazodone for dogs? Can you send home your meropenem to be given at home? And do you need any NSAIDs? Start it before they come in. Now, tramadol actually is effective in cats, but it's very bitter. Good luck getting that in them. In dogs, quite variable because of the way it's metabolized. So we're not using that as much in dogs anymore. Think beyond drugs, though. Think about, when I talk about physical therapy, it's not just going to the PT, the therapist like that. Make sure they can't traumatize themselves. Use the e-collars if we have to. That's very important. If the dog is very active, young, guess what? They can have a sleepy vacation, keep them on trazodone if we need to. Don't forget cool compresses. Everything from washcloths that you wet, put in the freezer, bring back out. I wouldn't use bags of peas or anything like that. That can be kind of heavy. But even that half and half alcohol and water that freezes up in a baggie makes a nice, soft, cool compress. And then as we look at both post-operative protocols, but even chronic pain, this CC loop can be very helpful. And then we look at other things, everything from acupuncture to different modalities for chronic pain as well. So when surgery wasn't enough, I'm going to talk about chronic pain, specifically refractory stomatitis. I think more frequently I'm seeing cats that used to be really good at the 2-week visit. Now we're seeing moderate, mild caudal-mouth inflammation that extends a little bit more. So as we look at our pain management, we're sometimes extending that pain management a little bit longer. And I think I've been seeing this a little bit more. We do need to make sure these cats are definitely eating well. Check their weight at the 2-week recheck. If there's any weight loss, then we definitely need to get them on something to help support their nutrition as well. There are several things out there that have been talked about for refractory stomatitis. And the fact that there's a fairly good list means there isn't one thing that works perfectly. I know in Wisconsin, they go with a 25 to 50 milligram once a day doxycycline. Remember, the tetracycline, doxycycline compounds are anti-collagenase, not just for antibiotics. So that can help with some of the inflammation. Certainly, this is where we'll consider using the gabapentin even right after surgery, and we can certainly increase that as long as they're not too sedate, but they may want a little sedation at nighttime. The 1-TDC, which is an esterified fatty acid, we'll consider using it that's applied to the gingiva. Again, you have to look at how much you're putting into a cat that's already painful, so we have to look at that. And then duralactin feline that works with the microlactin compounds to help decrease some of the inflammatory components. Question about the buprenorphine buccal mucosal, how can we prevent it from being ingested? We dispense it in 1 cc syringes, and we tell them just to put it inside the cheek lining and squirt. So we're not opening up the mouth and putting it down. We're actually trying to get it inside the cheek lining. And that usually has been pretty effective. All right. Remember I mentioned FOPS, those Burmese. Stresses of dental issues, whether it's teething or dental disease, environmental stress. So we want to make sure that, maybe if they're having a stressful time, we think about pheromones, what we can do to change the environment. Using NSAIDs or corticosteroids typically have a limited effect, and once removed, it comes back. What has helped these patients has been phenobarbital. So looking at how this is a trigeminal nerve, it's almost along the lines of that neuropathic, maybe not seizure, but certainly close to it. And these anti-emesis can help. DACIVM has been listed, and even gabapentin has been talked about. And if you think about gabapentin, it's a seizure type drug and for chronic inflammation too. So it's an interesting thing. Now, TMJ chronic pain. If you have a cat that has been through trauma and has luxation or fracture or any kind of injury to the TMJ, even if it can be repaired, it can end up getting ankylosis and osteoarthritis later on in life. We'll usually see this if we have range of motion that's decreased, there's grinding or whatnot, and certainly advanced imaging is very important, especially in the retrobulbar area. Now I put this picture on here to show a couple different things. First off, when I have TMJ issues, whether it's luxation or fracture, even jaw fractures, there's a couple things we do that every clinic can do. You see where the endotracheal tube is coming out? It's transmylohyoid. You make a stab incision, just lingual to the mandible at the first molar, and you can bring it out that way versus doing a pharyngostomy incision. Much simpler. The other thing we do is once a TMJ has been relocated, the luxation has been reduced. We don't want them opening up their mouth too far, but we still want them moving the mouth to maintain some motion there. So we use sewing buttons called labial buttons, one on the upper right, one on the upper left, one on a midline ventral, and connect it with a heavy suture to allow them to open up their mouth, but not too far. And those buttons, you can even buy some cute ones and use it that way. So now let's talk about chronic pain management in general. And the term maladaptive, I think, is trying to be used more than even chronic pain, because this is where we get that wind-up effect, and we get nerves that are reactive even if there isn't a big pain happening. So certainly, as we look at multimodal with osteoarthritis, generally TMJ, we want to decrease pain, we want to decrease inflammation. If we're going to use gabapentin as some of our chronic pain management, like starting lower and gradually increasing it, and you can go up to 10 mg per kg BID, I think higher than that in some cases, but you never stop it abruptly. And remember, it's becoming a scheduled drug in some states, so we have to watch out for that as well. Thanks to people, they mess lots of things up, don't they? So chronic pain management, I think as we look at that physical treatment, not just physical therapy, there's a lot of options out there. And as we talk about oral pain management, there's a little bit less. Doing an underwater treadmill won't be very helpful here, but we can still use some of the concepts of physical treatment. Things such as acupuncture, a massage with different points can be helpful. And one of the things that we're certainly looking at and using is a targeted pulsed electromagnetic field, TPEMF. There's been studies with post-surgical in other areas in pets, osteoarthritis, and it's been used in the human field for quite some time. So these loops, this targeted PEMF, basically there's a field that is produced from the loop in a barrel-like formation, and this technology enhances endogenous nitric oxide production that helps increase blood flow and modulates cytokines and growth factors. So as we're looking at trying to get this to heal better, we're going to get decreased pain and edema, increased tissue repair. So the products are composed of coils, these loops, which create the treatment field, kind of barrel-shaped on either side, and the area to be treated needs to be in this field. We look at 15-minute treatments. Typically, we'll start about 2 per day, and usually it shuts off right at that 15-minute time. So some of the veterinary clinical trials, in addition to everything that's out there on the human field and even the equine field, hemolaminectomy post-operative, luckily I'm not a neurosurgeon, looking at decreased pain perception, the ones that regain pain perception, but proprioception and statistically significant less pain, return to function, return to walking, and reduction in opioid need. In people, they are very aggressive at treating pain early, but then getting the patient to function as quickly as possible, looking at those patient outcomes, and then going to alternative modes to get them off the opioids as quickly as possible. And this is one of the areas that can be used in patients as well. So there's the lounge. When you have the smaller animals, when you have the cats, ideal not just for oral surgery, but chronic osteoarthritis, full body conditions. If there's an itis, let's see what helps. These are rechargeable. And some of the smaller sizes can even be used in carriers, cat carriers, and then there's the larger loungers as well. We now have a dental loop with the Bonnet, a little bit more cost-effective because that's a total of 60 treatments. And it has a slightly smaller loop for specific application of the head and oral cavity. The 15-minute treatments twice a day, you can get up that 30-day, 1 month. So if that 5 days worth of buprenorphine isn't quite getting those stomatitis cats and they're still having some inflammation 2 weeks out, here you can definitely use this for a little bit longer. But it's not as extensive as the larger loops, or like the lounges. There's also bonnets, look, soft tissue, soft fabric, and you can position the loop within the bonnet to help get it in the area around the site, or sit there with your pet for 15 minutes. Depends on the pet. So again, slightly smaller than the other loops, can be held in the area, can be used with the bonnet. All right, some other things we'll talk about, not just pain, but inflammation. Remember I mentioned that low-dose doxycycline anticollagenase works on inflammation. The cyclosporin works on the immune system. And there have been some studies with some reasonable, not everybody's cured. That's, like I say, why we have so many medications out there, or possibilities out there. Duralactins have the microlactin that help decrease the inflammation from these upregulated white blood cells. And then the one TDC that I've mentioned, I don't carry it. I just tell my patients, my owners about it. It's listed for oral inflammation and osteoarthritis, which I think is an interesting combination, but think about that chronic inflammation. So let me go back real quick, since we're still on some of our pain medication. Do not stop gabapentin abruptly. If they've just been on it for a week post-op, then you're probably okay. But if you're using it for chronic issues over about 2 weeks or so, then I'd gradually reduce it over the next week. So we don't want to have any rebound pain. So as we think about these patients, we know that we want to manage all the aspects. We want to manage the preoperative. We want to manage during any surgery, certainly after any surgery, and any chronic issues as well. We're going to see whatever we can use for that particular patient and use what's necessary. Now, sometimes as we go this multimodal route and they're feeling better, we're not sure which one, we need to keep them on if it's a chronic type situation, but work with whatever you need to do, including anything the owner can do at home to help provide that analgesia. Because as we look at discomfort, as we look at pain, that impacts our quality of life. And I'm going to put another bit in here for the inflammation. More and more research is looking at chronic inflammation, not even the pain. So if you have that inflammation, you have an area that's not healing well, think about how the nitric oxide stimulation can help. Think about how some of these compounds can help. Because chronic inflammation can actually impact immune health and aging all along the lines.